Right. Good afternoon, everyone. I'm not going to be fancy and put any sort of blaring intros or even any of the countdown timer stuff, but here I am. We're actually at the Choose Health Group's managing director's house because we just had a board meeting and we didn't do it in the office today. And so this is quite a cool backdrop, very casual. If the internet holds up, that's the danger. So hopefully, me and my good friend Brad Neal are going to be talking about all things knee pain, adjuncts, and stuff. What associated things alongside rehab might we feel qualifies and doesn't for integration into your care of knees? Because it's Knee Month on Physio Matters. Did a session last week on that, which went down well. Sort of clinical topics. Got a few more coming in later in the month as well, including a session with Angela Jackson on young knees, a session with Janet Thomas on older knees, as well as some red flag stuff as well around the knees, a couple of serious pathologies that I missed earlier in my career that I don't want you to miss. So there's a few bits like that that are very knee-centric, but when it comes to knees, my favourite person in that direction is Brad Neal. Great thinker and someone that, especially on something like this, where a really reasonable balance of what is a sensible application of evidence rather than sort of narrowly. He's not one to sort of wave nice guidelines and be over empirical about this stuff. He's a great pragmatist, so I'm really pleased he's able to join me. I hope the internet sort of signal holds up and stuff like that. If you lose us, I'm sorry, but me and Brad will sort of patch something together, no doubt. We chat about this stuff at least on text message semi-regularly, so we'll patch it together in case there is a dropout. So sorry if you lose us. We won't try and boot the feedback up. I just can't trust this internet. But if it does happen, then I'm sorry. For those of you that are tuning in live, of course, please love to hear from you. Get your comments in. Always seem to have more interaction on a Friday, so I'd love to join you. Love for you to join us there with any questions and comments. But equally, if you need to after the fact, then please do leave your comments there. We'll get back to them, or email info@physio-matters.com, and that'll be good. I'd rather, I think, lounge back in this chair. So I'm going to remove my little background and hopefully bring you Brad Neal. Oh, I don't know if I like you being that side of me. Let's get you over there. Right, Brad, can you hear me, mate?
Yes, mate. Yeah, much prefer the second side of the screen as well.
Oh yeah, we don't want you over there on that side. So I'm gonna lounge your cash right over here for a bit. Can I get your opening remarks in a way on this subject? Because me and you often are talking about talking about rehab, talking about where we might target change or exercise. We might talk about run retraining and stuff, which is certainly central to your PhD on the subject. But I don't think we've ever focused it so much on sort of the accessories. What do you consider core and what would you consider accessory when it comes to, say, the knee? And bear in mind, we're not talking about the kneecap specifically for a change.
I was going to say, you're throwing me there, asking me to talk about the entire knee. I think I think if we think about it as a core, if we see knee rehab as a big umbrella, core interventions being formed in some way, shape, or form of good quality education, behavior change techniques, and some form of rehabilitation, whatever flavor of exercise you're into at that particular time. I doubt many people would take too much umbrage with that as being a core approach. I think beyond there, where we go with accessories, adjuncts, whatever we choose to term them, I think that umbrella then becomes too big. For example, if we look at tape, do I think there's good quality evidence for a short-term effect of tape in something like PFP? Absolutely. Would that extend to knee-OA? My understanding would probably be not. Whereas if we look at bracing, perhaps via different mechanisms, bracing in PFP, bracing in knee-OA seems to be a relatively sensible thing to do. Injections probably going to differ quite heavily between those two pathologies. So I think it depends so much in terms of who we're talking about and what pathology they're afflicted by.
Yeah, absolutely. Oh, affliction. That's a word I haven't heard for a while, but yeah, like it. Afflicted by knee pain. Right. Now, let's make sure we break things down then steady. But I think that's the appropriate caveat we need to put in play, isn't it? That, of course, it depends, and it depends on several different levels, both in terms of what pathology we're discussing, in what population or cohort, and what might the evidence inform, but then what clinical reasoning variables would we bring to bear over that decision-making process, right? So that sounds like we're in the same place. But I want to sort of possibly go straight for what do you think you would struggle to make a case for, right? Because there's got to be some stuff that are adjuncts in some people's quiver that you and I might not touch and wouldn't feel are defensible, or it would be such a narrow circumstance that you could find a way to justify it that we don't recognize in our practice. So can you think of any off the top of your head, or that you've given thought to before, or maybe that used to be be in the mixer that no longer are for you with regards to adjuncts, that if you heard that being done on someone's knee or for someone, you'd struggle to make a case for it?
Yeah, definitely, and I think an easy place to hang in terms of where my practice has changed would be based around needles. You know, be it acupuncture, be it dry needling. No different to a lot of musculoskeletal physiotherapists. You know, I was down that road at one point and did the course as part of my MSc, and bizarrely, and whether I should try and hide it or not, I don't know. But my first ever published paper was a sort of theoretical piece on whether there would be a role for needle therapies in tendinopathy. But if I think about knee rehab and the typical sort of persistent knee complaints that people present with, I'd struggle to see a place for, be it needling for pain or dry needling. You know, we've got a big review of all the high quality randomized controlled trials for PFP underway at the moment. You know, we would say the needling combined with exercise offers no additional benefit, and needling compared to sham needling appears to be ineffective. So I think that's an example of somewhere where my practice would have changed, and certainly where we can say you'd probably struggle to convince me of either the empirical evidence or the clinical reasoning evidence for considering that. But then we could very easily flip that round, in that if we look at something like Musclestim, which is relatively popular, particularly for someone with a load intolerant knee, be it because of pain or be it because of surgery, you know, it's often something that's purported as being a useful thing to do with sort of reasonable biological plausibility behind it. Again, for PFP, there isn't the evidence. You know, it's just not there. You know, whether we look at Musclestim combined with exercise or Musclestim compared with sham, doesn't seem to derive an effect. Yet it would probably be used as frequently as perhaps something like acupuncture. But I'd imagine the masses would probably have a bigger problem with the needles than they would with the buzzy pads. So
Got you, yeah. But then I suppose then if we think, let's stick on Musclestim and then start to venture towards the electrotherapeutic modalities, of which I think the catch-all people are bothered by. But then if you get into the detail, then something like Musclestim, and then we'll no doubt talk about Shockwave in a second as well, if you don't mind, then people are less averse in specific cases. But on the Musclestim, that's classically a post-op, classically a ACL recon. That you hear that being used and promoted, particularly early doors there. Can you just give me a bit of your take on because the one of the primary logic models I understand is that people suggesting that a swollen knee is then decreasing. I'm going to get my terms wrong here, of course, which will make your ears bleed. But, you know, with regards to, say, I can't remember if it's either the muscle recruitment or what have you, but the idea in which you get in people, old language being the activations and things like that. And it used to be quite targeted, people saying it will take your VMO out, whereas now we understand there to be some quadriceps inhibition, unless I'm perpetuating a myth there. But just what's your understanding in terms of that, because I don't think I've really heard of it being utilized, say, for PFP relative to it, but certainly post-op, ligament recon, that sort of thing. I understand it to be fairly well used. We don't, though, interestingly, and I'm not sure necessarily why. We don't have one in the clinic. Maybe we're not seeing as much of the acute stuff and much of the orthopedic post-op stuff. But yeah, just invite your thoughts on that in terms of its use case.
It's twofold, isn't it? It's either that attempt to reverse what's often termed arthrogenic muscle inhibition, muscles being the function of muscles being affected by an external factor, whether that's pain, whether that's swelling, or whether that's something else. So that's one sort of mechanism that it's purported to go after. The other being just that we have a load intolerant knee, and because you're 2 weeks post ACL reconstruction, I can't stick you in a leg press and put your body weight through your knee. So because we can't do that, let's increase the neural drive in another way by turning on something like a Musclestim. I think it's probably a good example of where the mechanisms make good, plausible biological sense based on our understanding of human anatomy and physiology, but an area where perhaps the actual efficacy or effectiveness data we have just doesn't back those mechanisms up. It's probably similar in a way to something like PRP, isn't it? You know, if you look at the basic science and the applied physiology behind why PRP might be a sensible thing to do at certain points in time, I think you could fairly easily be convinced. But if we look across the board at the good quality trials that have looked at whether those mechanisms derive a quality effect, doesn't appear to be the case. So I think we live in that tricky realm, don't we, where we either reason from one end of that spectrum or the other. You know, we either go at, and we've got clear effect here, we don't understand the mechanism, but that doesn't matter because the effect is there. Or we go after, this is a mechanism that makes sense, and therefore I'm going to target that mechanism irrespective of whether there's efficacy data or not. You know, we're kind of stuck, I think, at either end of that spectrum at times in physiotherapy.
Yeah, absolutely. And I think that over the years, I can't think of anything that's, if you had to delineate all of our communications between the two of us across various different platforms and styles, we've often ended up in that grapple, haven't we, between efficacy and mechanism, and both favouring each of those things at different times, depending on our journeys over the years of knowing each other. Because I think it is an interesting thing that you're grappling with. We know it's got to be plausible. That's where me and you are always looking and starting, and why I sort of more famously on this show, we'll talk about why we don't use horoscopes, etc., to try and almost think of a sort of cartoonish example of implausibility. But then also, we don't want to dine out on just mechanisms when we've got, say, the time, the opportunity, and it is in the literature where people sometimes will stick to that and hide from data that they don't like, that might go against their favoured modality, including, of course, rehab-based modalities or styles or types of exercise that they prefer. They'll put their fingers in their ears and not hold it to the same standard, which I know is a bugbear of both of ours. On the electrotherapies, then let's just go to Shockwave if we can. More, classically for tendons, but also increasingly seen in the both literature and its use cases in practice for things like OA. So just wondered if I could invite your thoughts. Obviously, lead with PFP if you prefer, as is your style. But just your thoughts there, because I know you have looked into and been involved in studies that have nodded towards Shockwave. So knowing you will have given that some thought.
My honest answer would be Shockwave isn't something that sits at the forefront of my thinking. Really, it's not something I've ever looked at academically or otherwise. Certainly clinically, it makes sense to me to a point in a model around a pathology like tendinopathy, where if our rehab strategy, again, whatever flavor you choose, be it heavy slow resistance, be it eccentric, be it isometric, whichever one of those you've gone at, if that isn't deriving an effect, which is common, right? Tendinopathy is a persistent condition and often fails to respond to what we consider to be good quality evidence-informed care. If you've got to look at a next step, it makes sense to me why we may be led towards something like Shockwave as opposed to something like corticosteroid, as an example, where we've got some indication of harm with corticosteroid. It may lead to necrosis. It may lead to rupture. Whereas with something like Shockwave, like many things that we do, if it doesn't help, it's probably unlikely to harm. So it makes sense as to why someone may go there. And it's often used as a sort of, we're going to do it rather than letting an orthopedic surgeon get their scalpel out, which,
sure,
again, I can understand, but at the same time, having been involved, albeit in no more than case series level data, surgical trials with Håkan Alfredsson, Lorenzo Maschi, I've given them some assistance on some big, relatively large surgical case series that we've published. Certain surgical techniques people can do very well with. So I don't personally like to see an intervention like Shockwave that may or may not be effective be lent on because we don't want someone to have surgery, when for a certain group, surgery may be the place to go, right? So
sure.
Yeah,
I've ended up in a similar. Sorry, there's a slight delay in there. I didn't mean to talk over you there, pal. But I think I feel that logic I've spoken about more, mainly because I'm more in touch with that literature, I think, with regards to OA knee. I think it's been a real mistake that people have, and sometimes even clinicians that I know and love that are in the same department as me, that I've cringed through the curtains at, that are almost can't help themselves but to demonize the surgical intervention to such a degree that they're sort of scaremongering, when fundamentally something like a total knee replacement, it's you can't make that mistake. That trying to motivate behaviour by demonising what is then as if there's this nuclear option that's we need to desperately avoid is remiss, when we now know that, especially in that case, this was when I was sort of my sort of extended scope APP role, where sometimes it is wise for you to say, look, this would be a bit drastic. Let's make sure we exhaust these other options. But fundamentally, there's a way in which you can use language that doesn't then demonize something like a total knee replacement, of which is an incredibly useful intervention and something that is, has a great safety profile, particularly in the right patient and stuff, and it's increasingly so as we learn more. And so I think that's what's interesting, isn't it? That sometimes that justification of, well, why not try everything that isn't a scalpel, when fundamentally the time, the energy resource, the even cost is something that isn't necessarily well balanced with some quite light touch surgical interventions. And whilst I don't want to go too far away from the knee for the sake of this, that is so obvious with regards to sometimes even, hour-long, never mind even day case stuff, even at the carpal tunnel, etc., that are increasingly being done and administered, even sometimes by physios, for those that don't know. You're in a situation where you're throwing the kitchen sink at something to avoid a scalpel when a scalpel is indicated, and it's something that doesn't have major consequences. You hear sometimes that in certain body parts, including the knee, whereby that is a bit of an old school model of reasoning that unfortunately is an understandable way that physios or other non-surgical therapists will end up doing, because they're trying to retain, they want to exhaust conservative management because that's their realm. And unfortunately, they don't realize they're succumbing to the sort of hammer nail fallacy of thinking that everything that they want to keep it in house. And so that's what does concern me with regards to that sort of surgical demonizing. Can you think of any other, obviously I welcome your thoughts on that if you do have anything to add, but also just on that electro, it'd be remiss if we didn't mention interferential ultrasound, pulse shortwave. I wonder, unless you're going to blow my mind now, Brad, I imagine they're not on your menu.
Yeah, no, definitely not. And again, I think, if we look at something like ultrasound as an example, I think this is what I would say to undergraduate students. Undergraduate students ever more coming into a curriculum, probably because of social media and various other factors, with their own sort of infant thoughts around certain things because of what certain influential people may say. And what I would say to them about something like ultrasound is, again, if we look at the basic science and the anatomy and physiology literature in terms of what ultrasound can affect at a tissue level, if delivered at the right dose, there's an effect there. Whether that translates into a clinical effect is another matter altogether. Whether we can apply something like ultrasound in order to facilitate the remodeling of a ligament, for example. If you work in the NHS, absolutely not. If you work in professional football, possibly, and it might therefore be part of your arsenal. But if we think about general practice or secondary care for knee pathologies, ultrasound, pulse shortwave, interferential, I'd struggle to see a place. I mean, interferential possibly leaning on to TENS, that could be a self-management strategy for people to use. Again, I think TENS is a nice example of, I think people always sort of drum up the idea of this caricature of a physiotherapist or other rehab professional bringing that person in 2-3 times a week just so they can use the TENS machine, when my sort of clinical reality, and this is what I would observe with my clinical colleagues, is that they'd send them off to Boots, they'd get them to buy one for 30 quid, they'd show them how to use it, and it would be fed into a self-management program containing behavior change strategies, exercise, weight management, etc. So I think we should be viewing them like that, if possible.
Absolutely, no, that's fair enough, and probably wraps a bow around those electro type modalities. A good one, I think, to go into because of we're grappling with efficacy data and mechanism of effect, there is quite a potent physiological change when you inject, say, a corticosteroid into the knee. And I know me and you, it's a while back, and I don't know if you'll recall it, but we had some interesting back and forth in public. I remember on Twitter about sort of when injections for what that was and wasn't doing with, say, bony bruising, and we were saying what indications when we have MR, and it ends up being a really interesting area of applied reasoning because of the way in which patient selection into some of those trials becomes really important. But they are a really common intervention, particularly for OA. You find them in the NICE guidance until recently, but also because of the way in which the synovium is a continuum, means that then, I know it's something that you've given thought to and needed to with regards to what its mechanism is, even at the PFJ. So just your general thoughts on injections. Let's just stick with corticosteroid if we can for now, but I'm sure we can get on to other bits around the knee as well.
Yeah, again, I think with something like corticosteroid, my very much my clinical bias is I'd like to see it targeting something where the physiology makes sense. So a persistent patellofemoral pain patient who isn't responding but has a relatively normal MR outside of what we would expect based on their age and activity level, I'm not convinced that's defensible. But someone with patellofemoral OA or tib-fem OA who has clearly got a synovitic knee, there's definitely a more defensible argument for one rather than the other. And I think that's when I would often lean on our understanding of potential benefit versus potential harm, where would I rather someone in that situation have a guided corticosteroid injection from skilled hands, or would I rather them continue to go through naproxen or ibuprofen by the packet load and be at risk of something like a gastric ulcer? Again, my understanding is the potential for harm is greater with oral medication than it would be with an injection. So that becomes a different answer if that person has a second and a third and a fourth injection down the line. Then you start to think, well, what's the reasoning here? So, if we lean on the anterior knee, if someone's clearly got a hypertrophic fat pad and we're going after the mechanism of corticosteroid will have an atrophy effect within that adipose tissue. Again, the mechanism makes sense to me. If we're just doing it blindly because the person hasn't responded and we're looking to titrate their care, that's when I think we could perhaps think a little bit harder.
Yeah, I think that's interesting as well, because with regards to the guidance part of that is that you can make sense of guided and need for specifics with regards to, say, fat pad under the mechanism you just described, but then also but if you were trying to, getting a needle safely into a knee joint, you can't think of a safer unguided or surface mark guided injection. And so that's one of the things that really always depends as to what your target is. Always depends on what the rationale is and where it is you want that end of that needle to be, both in terms of exactly how it's delivered. Because I think that makes a decision on clinical reasoning on a pragmatic level, at least, with regards to access to those sorts of things when it comes to, say, guided versus unguided, or whether you have skills in team, or whether or not that needs to then go through another 6-week wait for a specific clinic that only 1 out of 10 local GPs do. These things make a difference to your reasoning with regards to the time frame that patient's on with their own goals, and so that's one of the things that we need to make sure we don't sort of over sterilize that reality and recognize that those variables, access, the time frames in which you can then do that, who, under what circumstances, be that guided or unguided. I think that should all color your reasoning. And who the hell are we in every given circumstance to know exactly what factors are at play, compared to, say, the clinician with that patient making those decisions. And I think that's why we end up always throwing his hands up and saying it depends, is because we're talking about just one. In this case, let's just say we're fairly close to 1 or 2 pathologies. We're talking about one modality, but the variables that we can't know of that are related to any given case study is such that there's too many of them. We can't make those guesses, and that's why we should be training and supporting each other to make those decisions, not hard and fast rules, and ruling things out over the top, because people are sometimes that is tempting. It's tempting though, isn't it? It's tempting to just have things that you're just totally writing off all of the time and become quite nihilistic about. Which I know, again, you've spoken on this show and elsewhere about the fact that that's not your preferred sort of reasoning style. Is injections one of those whereby people seem to be for or against, when of course it's somewhere in between?
Yeah, definitely. Yeah, it's definitely in that battery of things where people have got very, very strong views in one direction or another. And I wouldn't claim to be an expert at all on sort of when the guided versus unguided decision is best made. I'm reflecting on my practice whereby, and whilst again I hold my hands up and say I haven't seen a patient actively for almost a year with my recent career change, but historically, injections in my practice have always been delivered by colleagues with ultrasound guidance, and that's how my practice has been shaped. But I certainly wouldn't say that that's the only way that these things could go. And but if we're thinking about that bucket of things where people have got very strong views, we should probably tackle the manual therapy question, shouldn't we? Because it's in the title, and I'm sure people want to hear. And interestingly enough, you can. Whilst the Danish Sports Congress unfortunately didn't go ahead, it was another casualty of COVID. The abstracts from there have been published. So the abstract of this big systematic review that we're working on at the moment is available. It's in BMJ Open Sport and Exercise. And there's primary efficacy for the use of lower quadrant manual therapy in people with patellofemoral pain. Is it an outcome we were expecting? No, but is it there? Yes, it is. So I think again we have to accept that there are situations where these manual techniques, and what we're talking about, sort of global manual therapy here in terms of lumbar spine manipulation, hip, knee, etc., rather than kind of someone doing some patella wiggles, as Claire Robertson likes to describe them. So I would often, for sort of the wider manual therapy argument, I would, again, thinking about analogies I give students, someone comes in to see me post ACL reconstruction with 20 degrees of fixed flexion. Am I going to jump up and down on their knee and try and facilitate that restoration of normal extension? Absolutely. If someone comes in with grumbling OA and they're lacking 10 degrees of flexion, am I going to spend time focusing on that with manual techniques? Probably not. And I'd like to think I can defend that line of practice if I needed to, So,
but there isn't any sort of specificity that you bring to bear on that. Some people love to focus in on, that's because you're not getting this. We do a lot of tibial rotation mobs, or we do fibula head, or these quite specific techniques and things that I guess some people like to claim are not just skilled in terms of identifying, but also there's a particular angle in which you need this particular part of your thumb on. You don't see any justification for that, rather than the data's coming through to suggest that there is a signal there we need to understand better.
Yeah, definitely. And if I think about the tib fem extension mode that I do, why do I do it like that? Well, we're quite comfortable that in terms of arthrokinematics of the tib fem joint, when we go into extension, we generally see a posterior glide of the femur and an anterior glide of the tibia. What's easier for me to do? It's much easier for me to press on their femur than it is to try and pull on their tibia. So I do it like that, and it's comfortable for them. So, and I think that's the sort of narrative that's coming out of this systematic review. Again, there's an outcome of combined interventions having primary efficacy, and sort of isn't particularly scientific in the way that we're looking at it. But is that as straightforward as doing more things makes people feel better in the short term? It might be something as straightforward as that. And if we lean on all of these short-term effects, when one is in pain, the positive natural history that someone might be dangling in front of you that will come at week 12 or week 30 or whenever it may be, it's not always that easy a pill to swallow, is it, when you're in acute pain? So,
well, exactly. Yeah, I think we can understand that, can't we? I think as well, we've just got to always remember that these do end up being discussions around definition of terms, right? A skilled pair of hands holding on to a limb and taking it through a range of which someone's been otherwise avoiding. Why on earth is that not manual therapy? I don't know what it is if it's not, right? But if you try to define it narrowly as being specific glides, etc., and manipulations of a joint with regards to aspiring to what now are quite dated mechanisms of bone setting and the like, or cavitation as a means of suggesting it is a physical adjustment. Those sorts of things, of course, are easier to lampoon. But instead, it's like, really, what we're doing there is actually sometimes making people feel like they're being cared for in such a way that also there's therapist participation that can sometimes get that buy-in. And it's very difficult to measure. It is the art rather than the science sometimes, but we can also use the science to inform that decision making and to make sure we're not whispering sweet nothings into patients' ear about what some of these adjuncts are doing. The fact that they're adjuncts is suggestive that they are accessory to core care, of which I know me and you do agree on. It doesn't make that easy. It doesn't make it simple. Doesn't mean that that's the recipe and this is where all the interesting stuff is. But it's just that if these things are applied with those wider goals in mind as a means of scaling someone's function towards their own personal goals, then why are we not all winning from that? As long as that explanation and the narrative that you're then integrating into it isn't one that then has that as where the special stuff is, right? That people not necessarily become frothing addicts to it, but just generally speaking, that they don't perceive that there is some magic that has just been delivered to them. And that's one of the reasons why they were able to train. It's fundamentally trying to help them to realize that, if anything, these things, look how adaptable your body is as a means of it. All it took was me just helping it along its way and offering some reassurance that could be via touch, via tape, via sometimes even a slight temporary disruption to your physiology in a positive way from injectables and the like. And I think that just trying to make sure we understand how to best articulate that is, whilst not easy, is vital. And so I think that's certainly a takeaway from me. Just some closing thoughts on you before we wrap, mate.
Yeah, no, absolutely. I think it's an area where, I mean, philosophically, I'm not convinced I'm that comfortable with the term adjunct, because we'd see orthoses as an adjunct, or people see orthoses as an adjunct, but actually their number needed to treat is better than that of exercise, and they are comparable in their efficacy to exercise. So I think that's maybe adjunct might be the right word. What we label as adjuncts is maybe the bit that's wrong. But I think we all just need to be a bit more accepting of what we don't understand, in that people would perceive, my estimation would be that people would perceive the football player that needs the K-tape on their hamstring in order to function well as being a problem. But they'd probably be okay with the footballer that needed to stick a band on and do some crab walks in order to function. And they're one and the same, aren't they, ultimately? So my thought will always be, what efficacy data do we have? What mechanism are we targeting? What's important for this person? And therefore, it's always going to be slightly different each time.
Yeah, and even further than that, people would be there's some people who would be concerned if a player was particularly into a particular stretch routine, but if they then swap that out for a set of squats and lunges, but they still perceived it to be ritualistically essential for injury prevention, which is just as much of a fallacy as stretching, then essentially they just prefer that. And it's just about whatever is in vogue. And so we need to make sure we need to be more consistent with what it is, and also probably recognize it in our to our taste, by the sound of things, it's being pretty understanding and not especially bothered about either, rather than it being like you should direct your ire equally. It's like, no, there shouldn't be any ire. So yeah, I really appreciate that, and thanks again for your time, mate. I lean in to press the right buttons to cut us off now, and thank you all for joining. Really appreciate it. We will be on for more Chewing It Over next week. Mondays and Fridays now the show runs, and so thanks again, Brad. And I understand you've just booked in for our super secret show in April, which we'll be telling you all about soon. So see you in the middle of the night sometime in April, mate, if not before.
Nice one. Thanks, mate.
All right. Cheers. Take care. Bye, everyone. Have a good weekend.